You're listening to This Week in Cardiology from theheart.org on Medscape.
You can now access the latest in medical news on your Amazon Alexa-enabled device. Join me, Perry Wilson, every weekday morning for Medscape Medical Minute, where I highlight the top medical stories of the day. To add Medscape Medical Minute to your flash briefing, search for Medscape Medical Minute on Amazon and click Enable. Or open the Amazon Alexa app, go to Skills, search for Medscape Medical Minute, and click Enable. Then say, Alexa, what's the news? Or Alexa, what's my flash briefing? I hope you'll join us.
Hi everyone, this is John Mandrola from theheart.org Medscape Cardiology, and this is This Week in Cardiology for April 10th, 2020. Of course, it is not a normal world. It is a COVID-19 world. First, the numbers. It helps me to look at these each week. When I recorded last week, there were 250,000 cases in the United States. Today, there are nearly 500,000. The rate of rise is about doubling, is less than the week previously, which had seen a threefold rise. Again, testing greatly affects the case count. So let's look at deaths. Last week, there were approximately 6,000 deaths in the U.S. Today, there are about 16,000 deaths. So the death rate increase of 2.7 is substantially less than last week's fivefold increase. While the view from many overburdened hospitals in New York could hardly be called good or optimistic, it seems to me that a slowing in the rate of rise of deaths is encouraging, albeit with a big dose of caution. Worldwide, there are now 1.6 million cases, but still only 360,000 recovered, meaning that there are more than 1 million cases unaccounted for. That is a lot, and again, there's not only great uncertainty over the denominator, but also over the numerator. So the first topic today is yet another week has passed, and I guess I, still don't have much of a handle on the epidemiology of this disease. While the models are all super complicated, the big question at hand is quite simple. How many people have this virus, and how many get super sick and die from it? Basically, numerator over denominator. Months or years from now, when serology is available widely, we will know this data. But right now, there are only estimates. And of course, there is the precautionary principle. One thing is for sure, there is tremendous variability in how this disease presents. For instance, Professor Nupur Raje, and I'm sorry, I may have mispronounced that, is a doctor and wife of a friend and famous electrophysiologist, Professor Jag Singh, who both practice at Mass General, and she put out a Twitter thread on their experience with COVID. And I'll link to that thread. She describes in very poignant prose how sick her husband Jag became with coronavirus. He eventually ended up being admitted to an ICU, but not intubated. He's now home, thankfully. But throughout this whole thing, caring for her husband, working in the same hospital, working in the same city, she tested positive for the virus but never got sick. Not sick at all. And I've followed her Twitter feed, and even after 14 days, she has remained totally asymptomatic. Now, you probably know of similar situations. At my hospital, I know a doctor who tested positive and literally had 0 symptoms. So if you only have a tiny bit of curiosity in your body, this boggles the mind. I started the podcast with the knowledge of the epidemiology because it's everything. We have a massive and public health experiment that's ongoing in real time. On the one side of this equation, this therapeutic equation, you have the disease COVID-19 and its potential harms, for which we depend on modeling. Now, I will add that we're doing modeling without wholesale testing. There is no doubt that COVID-19 could be a devastating pandemic, and the precautionary principle holds. You don't want to have a 1918. But on the other hand, and I don't think it's talked enough about, is the therapeutic side of this equation. We are shutting down the economy, and we are plunging millions into unemployment, and no one disagrees that this therapy will cause definite harm. For sure, 100% this will be harmful. Just follow the economist Tyler Cowen, or go out in your city and look at the businesses that are just on hold. Many of these businesses won't come back, and in the U.S., many of the millions who lose their job will also lose their health insurance in a pandemic. Okay, a couple caveats on epidemiology. While you can find preprints, and I will link to one, which look at the influenza-like illness surveillance, ILI surveillance, and it makes estimates that millions of people have this disease. You also have reports from New York City that suggest recent surges of people dying at home. So one of the issues I worry about is the uncounted COVID deaths of people who never make it to the hospital. And as reports of the cardiac manifestations of coronavirus become known, it's hardly implausible that sudden death from, say, COVID myocarditis might be relevant. The Heart.org Medscape Cardiology has a nice recap of a circulation study from Columbia University researchers, and I'll link to that as well. A second caveat, there's a clear distinction in how this virus sickens and kills people. Professor John Mandrola published an analysis in a preprint form looking at deaths in hotspot cities and countries. He and his authors dichotomized death rates based on age, above and below 65. Now, anytime you dichotomize anything, this is a lightning rod for criticism. So the paper's methodology and conclusions were indeed highly criticized on social media, but its findings that coronavirus mortality is much higher in older individuals and those with comorbid conditions is becoming increasingly clear. And as I write this script for the podcast, I just saw a report from Ontario. I'll thank Swapnil Hiramath, which showed that over 50% of COVID deaths there in Ontario were from long-term care facilities and retirement homes. This predilection to older and sicker people will have to someday soon play into the mitigation strategies. When we learn more about the epidemiology, Professor Unity's contention that older, sicker patients may need extra protection seems hardly controversial. What's more, I'm currently finishing my first of 2 weeks of telehealth. My EP partner and I are doing 2-week stints in-house for emergency procedures and 2 weeks doing telehealth so as not to be sick at the same time. And one thing that is entirely clear in talking with my patients this week via the telephone and video is that my older patients are totally fine staying hunkered down away from people and trying to avoid this virus. A bit more on telehealth. I've mentioned this before, but after a full week of doing only telehealth, I am even more convinced that this will stick after the crisis passes. My patients seem to love it. I have reviewed Cardia and Apple Watch recordings. No, it's not the same as a 12 lead, but it is something. Many patients who I talk to have their blood pressure and heart rate recordings available, and most of the patients an EP doctor sees already has had an echocardiogram. So I ask, if a person can tell a good story, and I can see her general appearance on video, and I know she has good vital signs, and a normal echo, tell me again why an exam is that important. I don't think it is. Another thing that needs to change. The week before I went on telehealth, I did a handful of pacemakers. And while I was doing the telehealth this week, I could review the patient's incisions over the video or over a picture. So I asked, why does an older person have to have an in-clinic postoperative check? Given the remote monitoring capability of modern cardiac devices, a bunch of device follow-ups, I think, could be moved to remote monitoring. I do realize there will be regulatory hurdles, and I had to order a couple of monitors for diagnostic purposes. But I am stunned by the amount you can do with an internet connection and a video or phone connection. Okay, main topic today is about possible iatrogenesis. The big topic I want to talk to you about is the possibility that we could be making things worse in the management of these patients with respiratory failure. Medscape led the way on this when Dr. John White interviewed the young, earnest, humble, and thoughtful intensivist Dr. Cameron Kyle Seidel, who, after working on the front lines of Maimonides Medical Center in Brooklyn, sounded an alarm that the approach to early intubation and vent management of these patients with COVID may need some rethinking. His first approach was obvious. He went to discuss with the colleagues in the ICU. Their response is, we cannot have multiple ways of management, and they sent him out of the ICU back to the emergency department. He felt strongly about this, and so his second approach was to get his observations out there, was to make a short YouTube video that happened to go viral. My friend, Dr. Andrew Foy, a cardiologist from Penn State, whom I have co-authored many papers with, alerted me to the notion that one reason COVID mortality once on the ventilator is so bad may not all be confounding by indication. It may be due to the iatrogenesis of 1, early intubation, and 2, strict adherence to established ARDS protocols. I am insanely interested in this topic for 3 reasons. First, personally, I'm a middle-aged healthcare worker with asthma, and I could easily be facing the need for pneumonia care. Second, this is an incredibly curious topic because it speaks directly to the most important part of evidence-based medicine, and that is the external validity or application of trial evidence to patients in front of you. And third, as an observer of medical doctors, I find the tension between established, often older physicians to younger upstart docs who use social media a fascinating topic. And finally, the fourth variable in COVID is the issue of healthcare worker safety. Some people have advocated for early intubation because it reduces aerosols, and that is not unimportant, especially in the setting of PPE shortages. Now, for those of you not on Twitter, here is an electrophysiologist short version of the controversy. Dr. Kyle Seidel and many of his colleagues, for instance, Drs. Laura Dugan, University of Ottawa, Dr. Josh Farkas from the University of Vermont, Adam Thomas from UBC, Roy Spiegel from Washington, D.C., and Scott Weingart from Stony Brook, and of course, Dr. Marco Garoni from Torino, Italy. These and others were drawn by their observations to pay attention to the thoughts of a famous pulmonologist, Dr. Luciano Gattonini, who, among others, penned an editorial in the Journal of Intensive Care Medicine. The gist of this is that they feel that respiratory failure from coronavirus is not a uniform type of disease. There are multiple phenotypes. Many of these doctors think the evidence from ARDS trials does not apply to many COVID patients, especially early on. A common way many of these COVID patients present is with hypoxemia that is severe and way out of proportion to how the patient looks or their compensatory mechanisms. Normally, our practice is to intubate patients when saturations get to a super low level. But this group believes strategies to deliver oxygen early is the best strategy. In Italy, for instance, they use CPAP with a special hood that we do not have here. CPAP, of course, in the U.S. is forbidden in many hospitals because it is felt to put healthcare workers at risk because of the aerosols. Another option this group discusses is the use of high-flow nasal cannula oxygen. Again, this may create more aerosols, but the notion is to delay intubation. Not to the point of not intubating people when it's clearly necessary, but also not applying evidence from other less novel diseases. The novelty these docs point out is the existence, in many but not all COVID patients, of a phenotype in which there is normal lung compliance and isolated issues with oxygenation. They worry, therefore, that this phenotype can be transformed into a more typical low lung compliance pattern of ARDS by the rigorous application of ARDS protocols that emphasize high positive pressures. For instance, one strategy the group thinks is super valuable is to have patients prone while wearing high-flow nasal cannula, which is far easier and safer than proning when on the ventilator. In fact, Medscape has a really nice piece from Tricia Ward, who chronicles the Twitter feed of Leora Horowitz and Vineet Chopra, 2 doctors on the front line treating COVID patients. These docs also noted the possibility of proning patients well before intubation. Now, here's the problem. These young caregivers have only their experience and common sense and, of course, plausibility. They all admit that they don't have randomized controlled trials. So online, Doctors Ajay Kurtain and Sunil Rao, two cardiology colleagues, and frequent debaters of mine, reminded me that I call for evidence in RCTs and things like hydroxychloroquine, but want to give the young critical care doctors a pass on their ventilator management. So in one way, Doctors Kurtain and Rao are right. We probably ought to have trials of vent protocols. But on the other hand, I was also drawn to academic family medicine doctor Raj Mehta's tweet. He wrote, following protocols based on evidence with uncertain generalizability to COVID-19 and without taking into consideration of clinical factors is not EBM. He then added, hopefully everyone is working with the same shared facts, and he agrees that we are in trouble if the evidence is selective. But it is important to distinguish disagreement over shared evidence and refusal to consider new evidence. The latter is a problem with novel diseases that we cannot assume the same old treatment works. This issue, this debate, is not academic or just about drama. It's playing out in our hospitals all over the place. Dr. Kyle Seidel had to take to YouTube. Others have DM'd me that the ensconced powers in their ICUs are unwilling to even consider changes in protocols. The question I wonder then, will the intubate early and use ARDS protocols prove to have made COVID mortality look worse? I think it's possible. You don't have to stray very far from the dismal mortality of patients in ICUs on vents to think that a better approach could substantially reduce morbidity and mortality. And I hope the ICU community will be brave enough to do these RCTs, and then, if these pioneers are correct, give them credit. A note on humanity. My wife, Stacy, tweeted yesterday a story on how she had to use a baby monitor to tell a dying patient that his family loved him. I am going out on a limb here, and I will say the no visitor policy for dying patients is wrong, super wrong. I understand why it is there, but still, this is totally inhumane. We can, and we should, we ought to find a way to make it work. Whether we use PPE for family or separate rooms, or God forbid we accept a modicum of increased risk, we have to stop this inhumanity. Finally, many news stories chronicle the fact that hospital systems are cutting healthcare workers' salaries, and I understand that too. Revenues are down. Cardiologists like me should have to accept pay cuts without any debate. But my opinion is that across-the-board cuts are crazy. Regardless of lower RVU production, those doctors, nurses, therapists, or anyone working with or around COVID patients should see hefty increases in pay, and that is only just. So that's it for this week. As always, I'm grateful that you listened. Thank you. Remember, if you like this podcast, please consider telling a friend, giving us a rating, or even writing a review on your podcast app. That helps others find us. Until next week, please stay safe. This is John Mandrola from the Heart.org, Medscape Cardiology.
You're listening to This Week in Cardiology from the Heart.org on Medscape.